Okay, let's dive into this. In today's explainer, we're tackling a true medical detective story. You, or maybe someone you know, has probably gotten routine blood work done, right? And buried in that absolute sea of medical jargon is something called an ANA test. So, what happens when it comes back positive? It sounds super intimidating, for sure. But today, we're going to decode exactly what that means and, honestly, solve the fascinating mystery of what this specific lab result is actually trying to tell you. Because right away, seeing a positive ANA on your chart, the very first question you naturally have is, should I panic? And the short answer is absolutely not. Seeing the word positive printed in bold on literally any medical chart can instantly spike your anxiety. But I want you to kind of reframe how you look at this result. A positive ANA, it isn't a final verdict handed down by a judge. It's actually just the very first clue found at a crime scene. It tells medical professionals that something might be happening, but it definitely doesn't tell us who did it or, even if a crime was actually committed at all. To understand why, we need to look at the basic biology of what ANA actually stands for. Anti-nuclear antibody. Think of your immune system as this highly trained elite team of security guards. Their entire job is to patrol your body, find outside invaders, like viruses or bacteria, and tag them for destruction. But, well, sometimes there's a glitch in the system. The security guards get a bit confused, and they mistakenly flag mark their own team's cell nucleus instead of the actual bad guys. These misguided markers? That's what we call autoantibodies. So when a test says you're ANA positive, it simply means these confused security guards have been spotted patrolling around in your bloodstream. Which brings us to clue 1. Let's move on and see how this builds, starting with decoding the titer dilution. Because look, just spotting the guards isn't enough. We have to enter the forensic investigation phase to measure the actual strength of our evidence. The titer is basically just a measurement of concentration. Imagine the lab tech has a sample of your blood, and they want to see just how many of these autoantibodies are crowding around. So they start watering down the blood, diluting it, to see how long it takes for the antibodies to completely disappear from view. If they only have to dilute it a little bit, say 1 part blood to 40 parts water, which is written as 1 to 40 or 1 to 80, that's a low titer. It's weakly positive, kind of borderline. It's literally like finding a single footprint at the scene. But if they have to water it down 320 times or even 640 times before those antibodies vanish, wow, okay, that is a high titer. That indicates a massive concentration of these rogue security guards, meaning a true underlying autoimmune condition crosses our threshold of concern and becomes, much more likely. And that leads us perfectly to clue 2, visualizing those microscopic fingerprints. And this brilliantly illustrates that the amount of evidence isn't the only thing we have. We also get to look at this incredible realm of microscopic fingerprints. To find these patterns, lab techs use a fascinating process called indirect immunofluorescence. They drop a fluorescent dye right into your sample, look at it under a microscope, and just watch how these antibodies bind to the cells. In the dark, they actually light up and glow in very specific geometric patterns. It is almost like reading constellations in the night sky. If the entire nucleus lights up evenly, a diffuse, homogeneous pattern, well, that's highly common in systemic lupus erythematosus, or SLE. If they see tiny dots scattered across the nucleus, called a speckle pattern, the investigation leans more towards Sjogren's syndrome or mixed connective tissue disease. Then there's the centromere pattern, where separating dots align exactly where chromosomes divide, strongly linked to a specific type of scleroderma. And finally, if the glow is clustered tightly in the center, a nucleola pattern, doctors immediately start looking at systemic sclerosis. These glowing visual shapes act exactly like the suspect's fingerprints, giving our medical detectives their very first major lead. But just as the case seems to be coming together perfectly, we hit a massive plot twist. The false positives. Remember how I said earlier that a positive ANA doesn't automatically mean you have a disease? Okay, this is where you can let out a huge sigh of relief. Because up to 15% of perfectly healthy individuals walking around right now have a positive ANA at a 1 to 40 titer. Let that sink in for a second. 15%. That is a massive portion of the general population. And actually, as we age, that probability increases naturally. Your body's security system just gets a little, trigger happy over time. But it definitely doesn't mean you're sick. In fact, there are a ton of outside factors that can temporarily trip your body's security alarm without it being a chronic autoimmune disease. Healthy aging is a big one, as we just saw. But viral infections like mono or hepatitis C, or even chronic bacterial infections, can cause a temporary spike in your ANA. It's just your immune system overreacting to a real but totally temporary threat. And even more surprisingly, Certain everyday medications, like hydralazine for blood pressure, can induce something called drug-induced lupus. It mimics the lab results of lupus and causes a positive ANA, but the incredible thing is, it almost always goes away completely once you just stop taking that specific medication. All right, let's move on to clue number 3. The DNA match, unmasking specific autoantibodies. Now, what's really interesting here is that if your titer is high, the microscopic pattern is clear, and your doctor has ruled out all those false positives, well, the investigation has to go deeper to find the exact molecular culprit. This is where your doctor orders a secondary, much more detailed test, often called an ANA profile or an ENA panel. And notice how incredibly specific these molecular markers get. The initial ANA test was just a broad sweep, but these specific autoantibodies act as the definitive forensic match for severe conditions. For example, if the panel finds anti-dsDNA or anti-SM, those are highly specific markers for lupus, often pointing to potential renal or central nervous system issues. If they isolate anti-SCL70, that points toward diffuse scleroderma, which involves widespread skin thickening, and anti-Jo1, that acts as a specific marker for inflammatory myopathies, giving doctors a massive head start on diagnosing muscle and lung inflammation. We really have to pay attention to these specifics, because not all autoantibodies carry the same clinical weight. Just compare the impacts of these two markers. If a patient has anti-Ro or SSA, this is linked to Sjogren's syndrome, but crucially, it can cross the placenta from a pregnant woman to her fetus, posing a real risk for neonatal lupus and heart block, so that requires highly specific monitoring during pregnancy. Contrast that with the anti-centromere B protein. This is linked to limited systemic sclerosis, or CREST syndrome, and while it sounds super intimidating, this specific antibody is actually associated with a generally favorable prognosis and a much slower disease progression. So you see, the exact molecular culprit literally dictates everything about the patient's future care. But through all of this high-tech lab work, fluorescent glowing cells under microscopes, and deep molecular profiling, there is a golden rule in rheumatology that every doctor follows, and it is beautifully captured in this quote from our source material: "Treat the patient, not the lab report." So the crucial point is this: an ANA test is clinically meaningless without physical symptoms. For a positive ANA to actually be relevant to your health, it has to be paired with a very real constellation of symptoms. We're talking about unexplained chronic joint pain and swelling, extreme, debilitating fatigue that just doesn't go away with sleep, a persistent butterfly-shaped rash across the cheeks and nose, fingers turning stark white or blue in the cold, which is known as Raynaud's phenomenon, or even unexplained recurrent fevers. If you feel perfectly fine, if you're walking around totally healthy, and happen to have a positive ANA, it's usually just an incidental finding that requires nothing more than watchful waiting by your physician. Because the human immune system is an absolute microscopic marvel, constantly balancing on a razor's edge to protect you every single second of the day. A positive lab result isn't a reason to panic. It's simply a fascinating window into that delicate biological balance. So, the next time you or a loved one looks at a confusing blood panel, I want you to ask yourself, what is your body's security system actually trying to tell you? Is it just a temporary false alarm, or is it the very first clue to solving the mystery?